Hello, everyone. So happy that you chose to spend a little time with me. My name is Kim, and I'm going to share with you what has been my academic and also research interest for about the past decade. And our objective today is to, as Charles Schulz so accurately depicts here, we're going to try to tap in to your inner Lucy. Any of you feel like you have an inner Lucy? I know as dental professionals, we do a lot of counseling. And so hopefully some of this will resonate with you. So I mentioned that I started about a decade ago, maybe just a year or two more, with motivational interviewing. I got interested in teaching our dental hygiene students motivational interviewing, which if you know what that is, you'll appreciate this. And if you don't yet know what that is, you will before we finish. And the thing I want to say about this is even 12 years ago, when this was very new, especially to dentistry and dental hygiene, Philips Sonicare was there. They were supporting me. They were sending me to meetings to speak, to kind of get the word out about this particular approach to patient-centered care. And lately, I have made the observation that motivational interviewing pairs really well with another topic that you might be hearing a lot about, and that's patient-centered care. So I know the American Dental Association has offered some continuing education. I think ADEA has also been involved in promoting not only motivational interviewing, but also patient-centered care. And so I highlighted some of the key words in the traditional definitions of these two communication approaches, counseling or communication approaches that help us to connect with people at the individual level. And we've been doing this in dentistry, dental hygiene, dental assisting, front office, all these things for a long time. But we've never really been supported with good evidence to support this type of approach. So let's explore maybe why we're looking at a new approach. So if you look at the bottom of your screen, you'll see a little Q&A button, and you can, if you'd like, you can enter your best guess as an answer to these questions based on your clinical experience in that little Q&A box. Also, if you have questions for me throughout the presentation, go ahead and jot them in that Q&A box, and I will address those at the end. So this is empirically supported research. It's in medicine, but we see very consistent results in medicine, pharmacy, dentistry. So the idea is what percent of health information provided during your encounter with the patient is forgotten within the first hour. What percent do you think the patient forgets in the first hour? So I'm seeing, so I started out with an optimist. She said half, and then everybody else kind of chimed in and said 80, 85%. So this is not a phenomenon that is new. You all know already intuitively that this happens. So I'll give you the empirically supported answer is between 30 and 60%. So we give them that information, they forget it probably before they get home. So that's not very reassuring. Okay, second follow-up question, what percent of our health recommendations are not followed? You can type in the Q&A if you'd like to hazard a guess there. So it looks like most of you are kind of sticking by your original answer. And indeed, about 50% of that information, those recommendations that we give to patients are not followed. And this is work by DiMatteo, about 2011 that demonstrated this. But it is widely supported. We know patients don't finish their prescriptions. They don't even sometimes fill their prescriptions. This is not unique to our role in dentistry. This is in all of healthcare, very pervasive problem. So what can we do about this? Okay, let's see if it'll let me advance the slide. There we go. Okay, so we're going to take a little breather here and actually practice one of the communication strategies that's used in MI. So given that we know patients don't always retain the information we give them, they forget it or they don't act on it. Now, you know, 30 to 60% forgotten in an hour and 50% not acted on. I would encourage you to kind of flip those percentages and think about the fact that somewhere around 40 to 60% is remembered, and probably that other 50% patients do try to enact. So it's not fatalistic at all, but I would like to do better than that. I would like to have more than 50% of my patients remember what I said, and also to, yes, lots of answers coming through on the Q&A. I know it might be a little slower for some of you, but you're all in that ballpark. So let's try this, for example. I'm going to ask you on a scale from 1 to 10, how important is it for you to learn patient-centered communication? And we're going to start with the group of you that are on the scale of 1 to 10, you're at about the X, okay? So that's about maybe a 3. So I asked a question on a scale from 1 to 10, how important is it for you to learn patient-centered communication? And you say, I'm a 3. So think about what your next question might be using this scale for just a second. think about that. Okay, so if I posed this question to you and you told me you were 3, MI teaches me that the follow-up question to ask you is, why are you a 3 and not a 1? Why are you a 3 and not a 1? Because if you talk about why you're a 3, you're going to talk about, well, it's only got a little importance. It does still have importance. So if we went the other way and I asked you, why are you a 3 and not a 5? You're going to tell me why it's not as important as a 5. But if I ask you, why the 3 instead of a 1, you're going to talk about what gives you that level of importance that's at the 3 on the scale. So it's not, it's not so much that any of this is rocket science, I guess I'd say, but it's just a way of trying to keep people on the positive side of the conversation. Now, if you were Y on this scale, and then I would also ask you, if you were still at X, if you were still a 3, I would then follow up and ask, what would it take to move you from a 3 to a 5? So what would it take to move you from a 3 to a 5? And again, the response to that is going to be, how much more importance would it have to move you to that 5? I'm not letting you talk about the stuff below the 3. I want you to talk about why it is important. And if you were high on this scale, if you use this in practice, and the individual, you could change this to, how important is it for you to learn how to prevent caries? Or this ruler can also be used for readiness and competence. So, how ready do you feel? How prepared are you to try this new preventive technique or to accept a particular type of treatment? And then we've got the Ys on the scale. So the Ys on the scale they're already more than halfway towards the scale limit of 10. And so we just want to say to them, sounds like this is already really important to you. Tell me what gives it that level of importance. So let's say they're at a 6. Tell me what makes it a 6 for you. And then maybe what would move you from a 6 to an 8 would be a follow-up. So this is just one technique of many that are part of motivational interviewing that I think can be worth our attention to help us deal with this particular, the evidence that our patients don't always adhere to our recommendations. We, as professionals, we want to do better. All right, so what's old is new again. This idea of patient-centered communication is not new. It actually was initiated by Dr. Carl Rogers. He's a humanistic psychologist, and it was back in the 70s, maybe 80s, when he started this, the humanistic psychology theories were very popular. But look what he says. He says that people, and I don't know that I conveyed this in the slide text, but the idea here is you're going to see this again. Human nature is that we will try to grow and develop if our environment supports it. So Carl Rogers said right before motivational interviewing that if we're genuine, if we convey acceptance, and if we express empathy, patients are more likely to pay attention to our message. And I think sometimes we get busy and we know we've got to get this message in and we've got to do it in a certain confined period of time. And we might be operating on a script. Do any of you feel like you use a script when you're telling people about periodontal disease? I want to make sure I remember to tell them X, Y, Z. We want to make sure that that script becomes more individualized and also that we convey these elements. Now, I want to draw your attention to the bottom of this slide, that empathy is particularly important because it conveys to an individual that they're being listened to and understood. You all know how to do this. You don't need to be trained in how to do this. You already have this skill. So let's dig down a little deeper. Okay, that was my pause for dramatic effect. So, the quieter you become, the more you can hear. Obviously, I don't think too many people would dispute that. But again, we find ourselves in practice environments, and this is true of all health professions. This is true of the pharmacists. This is true for the medical doctors. We are all confined by time. So I've got some good news for you about that. But this idea is that in MI, we refer to this idea of conveying to people that we heard them and that we understood what they said. And you might have learned this as active listening, that idea that by saying back to the individual what you heard them say helps them know that you heard them. So in MI, we call those reflections because they are pretty much in the words of the patient. When we paraphrase something back to them, they get to hear what they said one more time. And this is where a great deal of the psychology behind this counseling style is rooted, is that we're going to look at a theory in just a minute about how powerful it is to hear ourselves say it and then to have someone repeat it back to us. So we're going to construct our comments and our questions in a way that leads the patient to tell us something about their values, their desires, their ability, their need to take care of their oral health. And if you choose, which I hope some of you will, choose to actually be trained in MI. I too am limited by the time we have together tonight. I could not in 60 minutes teach you all you need to know about motivational interviewing. but I want you to have a couple teasers here. I actually push our students to move beyond the paraphrase to talking about the feeling behind the statement that the patient makes. So, and then also, what do they mean by it? I often find myself, my mentor taught me that when patients talk about things, they typically have, there's a meaning in there. You might have to tease around a little bit to get it. So these are the more upper level skills that MI has to offer us. But you can do the paraphrase, the active listening, as soon as you go back to work, because you know how to do that. So the next aspect we're going to concentrate on is this kind of spectrum of what does patient-centered communication, which MI is a type of patient-centered communication. We talked about the need to listen, really listen, and then paraphrase it back or deduce the meaning or the feeling behind it. And then we get to this thing in MI that you may or may not have heard of before called change talk. So we want to elicit from individuals change talk. Well, what is that and what does it do? And again, this is where the psychology is very powerful. So change talk is based on a self-perception theory. And basically, it is that it's human nature to become more committed to that which we voice. So the power is not in you saying it, because that's prescriptive, that's external. We're going to talk about that before we finish tonight. But we want the individual themselves to say that they could try that, preventive strategy, or they would be willing to cut back on their tobacco use, or they would be willing to, whatever it is that they express, they become gradually more committed towards that. And all of you know this. Think about, which are you more likely to do? That which you're told to do, or that which you offer to do? It's what you offer to do, because you said it in your own words. And so as we look a little closer at this is the essence of change talk. It's having the patient verbally express a desire, a reason, an ability, or a need to change. Those are characteristics of change talk. And then this theory states that if a patient or client expressed something that was opposite of the change we want them to make, let's say we did the ruler and we went the wrong way. The good news is that we are starting to see in the literature that sustained talk actually does not deter change. It's still someone talking about the behavior and hearing themselves talk about it, and maybe even hearing their previous barriers to it, limitations that stop them from practicing good oral hygiene or brushing that second time a day, or, using that caries reduction protocol, all those things, accepting that treatment plan, all those things can be reinforced by both change talk and sustained talk. Change talk is so powerful that when they do research, they sometimes do a regression analysis. I know half of you just fell asleep. But what a regression analysis tells us is how much of this change talk contributes to the behavior, because we know there's a lot going on in the appointment. And what the literature tells us is that that change talk is responsible for about 30% of behavior change. So if we added this to that 50% we were getting before, we could be up there where we want to be in terms of patient change, changing behaviors. Okay. So I recently came across this image and it just really drove this home for me. I forgot to mention at the beginning of the presentation that I am probably one of the world's biggest nerds. Not only did I move from clinical practice to teaching dental hygiene, but when I got involved in MI, I was so fascinated by the psychology behind it that I actually talked my mentor into going to bat for me so that I could be part of a doctorate program in psychology. So you can imagine trying to, yes, I will get to the resources, Kathy. You can imagine, she was typing in the Q&A, you can imagine, the last slide has those for you. You can imagine having to go through and take all the basic, I had to take all the coursework in psychology and do the background work. I was taking the doctoral level class, and these images remind me of my days in cognitive psychology when I was trying to wrap my head around, what do people know? How do they learn? How do they remember? So these images really brought back that background to me. I'm currently a candidate for a doctorate in, you'll love this, applied cognitive and brain sciences. So super nerd, I know. But these images show us that when an individual, so this individual was hooked up to an MRI, individuals, these are some samples, and they were going through a normal counseling session where they expressed change talk. As when you're trained in MI, you're trained in strategies to elicit change talk. It's not, again, it's not rocket science. But look at what it does. It activates the parts of the brain that deal with self-perception and intentions. So this is the neuroscience support for the idea that change talk is very powerful. That when we say we are going to do something, our brains are activated. There's neurological activity going on up there. We have a subconscious self-perception, and we are more likely to carry that out. So all these years later, this was from 2013, we proved Ben's self-perception theory correct. So I've been talking to you for about 25, 30 minutes about MI. I want you to know that this is not just my research interest and my bias that this works, but that there's really good evidence. And I've got a reference down there for you if you want to pull actual studies. I don't recommend it because that gets very cumbersome. But if you want to read all 900 clinical trials, I'll try to summarize what these say for you tonight. But 900 documented clinical trials of how MI works in a variety of settings. So dentistry, we've got the documented evidence to support this. I'm fortunate enough to have contributed to some of that. It does outperform advice giving in treatment of a broad range of behavioral problems and biases. So we've got clinical evidence to support this. Even more impactful is that when we looked at different subpopulations that received MI, it is particularly useful in minority populations. So clients who are already a little less motivated, a little less ready for change, a little more angry or oppositional. We don't get those people very often, do we, that are a little angry? No, never. Everybody's cheerful when they come to the dentist. They love it. So we know that there's good power in this counseling style. And so the bottom line is that there's evidence to support that MI is more effective than traditional patient education approaches where we tend to prescribe or dictate for patients what we want them to do. Remember, with MI, we're getting them to offer what they're willing to do. And the trick to this is you have to be able to let go a little bit. Maybe they're not going to offer to floss every day, but maybe they will offer to use an interdental aid 3 times a week. So we may not get the ideal behavior, but we know from early on at the presentation, they're not following our advice anyway. Half of them do, you know, the half that do. They go out, they're really, they're your patients that you have that connection with, and I know all of you do already. Half of them are going to listen to what you have to say. But for the other half, MI might be more effective, will be, there's evidence to support that it's more effective. Okay, my little trigger switch got, okay, happy there. So it also actually takes less time. It is, when you learn motivational interviewing, you learn to be somewhat directive. You're going to guide the patient towards the outcome that you're hoping to achieve. You're not going to dictate it. You're not going to give it, prescribe it to them, but you're going to lead them in the direction, kind of like we saw with the ruler. You're going to get them to talk about how important it is. We'll take a look at some other strategies before we quit. But this is the part that I think is exciting, both because you already know the top part of this slide, If I were to ask you, MI originated in the addictions fields. So what do you know about someone who has a substance abuse problem? What does it take for someone with a substance abuse problem to change? Can I tell them to change and they'll change? No. We know that people with addictive behaviors, they need to want to change. It has to be more along this higher quality motivation. We're back to intrinsic, extrinsic. This is Desi and Ryan's, as referenced at the bottom. This is Desi and Ryan's theory of motivation. I want you to notice, published in 2000. I pulled it from a 2017 reference. This is stuff we all learned back in psychology. Internal locus of control, external locus of control. In order for people to change, they need to have an internal desire, reason, ability, or need. Again, you inherently knew this, maybe not in this format, maybe not expressed like this. So when we offer them, I'm over here on the external regulation side. So what Desi and Ryan do is they take what we already kind of knew about intrinsic and extrinsic motivation, and then they start talking about forms of regulation. And so external rewards and punishments, trying to externally obtain compliance and reactance just doesn't work. At the next level, introjection is inherently external, but it kind of penetrates the surface. It gets a little bit involved on more of an internal basis. So that puts it in the somewhat external range. But if someone gives the behavior personal importance, conscious valuing, that self-endorsement or self-expression of goals, they're more likely to carry that out. And it goes all the way through to the highest level of intrinsic motivation, which is autonomous regulation. And so Desi and Ryan say there's three things that are really important to motivation. So if we went back to our first slide when we were comparing patient-centered motivation and the definition of MI, and we looked at a couple theories. We looked at Rogers' theory of humanism, and we looked at Bem's self-perception theory, and now we're looking at another theory. I kind of tricked you into them, I think, I hope. But for people to be motivated, these are the three components. They have to feel that they have a choice, and they have to willingly endorse it. They have to be able to do it. This is where we spend our time. They say, sure, I think I could give that a try. How confident do you feel about being able to do that? And then they say, not very confident. We can give them the confidence. We can practice with them. We can give them this. And then relatedness, I think that we do this very well with patients because we see them frequently. We probably already have a sense of relatedness with them, But you could take it one step further. I will sometimes say to patients in an MI fashion that let's say they've got a common problem, dry mouth. And I will say, would it be okay if I share with you what some of my other patients with dry mouth do? Okay, all of a sudden, this patient is hearing, I'm not the only one with this problem. They're not pointing a finger at me because I've got dry mouth. Other people have it. There are things other people have tried that helped. That relatedness, and I did it by asking for permission. It's kind of a hallmark of motivational interviewing. But could I share that with you? Is really more powerful than just the word suggest. So, autonomy, competence, and relatedness. Keys to contemporary motivation theory. So, traditional response, they may be a little bit exaggerated here, but here's what you need to do. If your gums are going to get healthier, you have got to do this more often, those types of approaches. As opposed to an MI approach where we might say, I might disclose that patient, I might show them their pocket depths, I might offer, if you are going to offer advice, I am not telling you not to offer advice to your patients. You have a wealth of information and they do want it, but they have to be open to receiving it. So MI uses the permission approach. Would it be okay if I share with you some things I saw today when I measured your pockets, or when I did your charting, or when I did your update or your checkup? Here are some things I saw that concerned me. And then ask them, what's your next step? What do you want to see? What would you like to be different? Oh, I especially like the hypotheticals. We'll get to those. So in a traditional approach, okay, we might not be this blunt. You could die if you don't stop smoking. It's true. We probably wouldn't say that, but we might tell them that they might suffer tooth loss if they don't stop smoking. So tell me what the benefits of quitting smoking might be for you. What might the benefits be? This is my favorite strategy because nobody's on the hook. You're just talking to me about what the benefits might be if you decided to cut back or quit. And by the way, I consider cutting back a huge victory. Not everybody's going to quit, but a lot of people will agree to cut back. So this is just a hypothetical question. Tell me what the benefits would be if you decided to quit. What might they be if you quit smoking? Then what we said earlier is they are going to hear themselves tell you those benefits, right? Self-perception theory, it's going to trigger self-perception and the desire to implement this in their brains because they're voicing it themselves. What I started to say, I think I deviated a little bit, but you have a lot of information and you're just going to ask them for their permission to share that information with them. And so that's kind of the premise that we build on. Would it be okay if I talk to you about your caries risk or the health of your gums or the treatment that would best solve your chief complaint, those types of things. This is my favorite magnet. You don't have to floss all the teeth, just the ones you want to keep. Our traditional approach. But we might say something about, you mentioned you didn't want to lose any more teeth. How could you go about doing that? Patients a lot of times know, or at least they've been to see us enough, that they now know what they should be doing. The power is in getting them to voice it, getting them to say it. Last example here, and then we'll start winding down. You must come in every 3 months. Versus, what are the benefits of keeping your 3-month appointments? If they say it, if they perceive themselves saying it, they will act on it. We've seen that, we've got evidence to support that. And then one of my favorite aspects of Emma is just to ask, what else? What else? You know, if I ask someone, tell me the benefits of giving up your cigarettes, if you might be, what would the benefits be of quitting smoking for you? What might those be for you? And if I ask them that and they say, well, my health would improve, don't jump in. Don't start telling them how their health would improve. Let some silence take place. Say, yeah, give them an affirmation. You're right, your health would improve. What else? What else? What else? Elaborate, get them to extend the reasons. They're probably not going to give you the really good stuff on the first response, but when you get a couple layers deep, you start to peel that onion back, and they start to say things like, you know, I don't like that my kids know I smoke. I don't smoke at home, but I don't like that they know I smoke. You know, values, personal value systems about why they might want to quit. So what else? Very simple, not time consuming. And then you take everything they tell you and you kind of repeat it back to them. You repeat back the autonomy. You're right. You know, let's say you ask them about the benefits. If they did decide to quit smoking and they say, nope, no way, every time I go to to a health appointment, they try to get me to quit smoking, I'm not interested. Now you've got some resistance, and MI teaches you how to deal with that. I would probably say something to that patient like, you're absolutely right. Now is not a good time for you to think about this. But I just want you to know that if you ever do decide to quit, I'm here as a resource. Because if they block you, if they resist you, they're not going to get to internal motivation. They're not there yet. They're not ready yet. But later, they probably will come back around and ask you about it. See it all the time in our clinic. So I mentioned to you that we teach our students to do this. Hold on. In our clinic, we teach motivational interviewing, not just in the classroom, but we also give our students, we do the recommended strategies, which are workshop training, coaching feedback. So they record themselves talking to a patient or a friend during class. They'll usually talk to a friend or a roommate, maybe even a classmate about a behavior change. And then they practice it in a clinic with patients. This was before COVID. So, but the conversation is face-to-face, eye to eye. And these are all the different types. So, preventive counseling, absolutely. Care plan presentation. If you want them to follow through, they need to be vested in this. They need to have autonomy. They need to feel like they have a say. If they say no, then just ask if you can revisit it another time. Tobacco cessation and substance and alcohol misuse. Sorry, that slide got a little bit, those words got a little bit mushed together there. Those are perhaps some of the harder conversations. I think MI makes it easier to have these conversations. If it is comfortable for you, keep it at a hypothetical level and then see how much personal buy-in you get. So during the semester that I'm doing the workshop style training in MI, I asked the students to do 2 recordings and I coach them. And I want you to listen. This is a first-year hygiene student in her first semester in the program. And I tell them specifically not to try to tackle tobacco use or substance abuse because they need the subsequent advanced skills to deal with those. But she didn't listen. She's as stubborn as I am. I'm going to stop the share for just a second and play some audio for you. This is a first-year, first semester hygiene student talking to a friend, it's not a classmate, about vaping. And we are picking up this conversation about a third of the way into it. So listen to what she says. And if you can't hear this, enter in the text chat about it. So here she goes.
Gotcha. There's no other downsides that you found? Nothing from like your day-to-day life?
Yeah, not anything specific. Well, like money-wise.
Oh,
I spent a lot of money on it, which,
Not
I could use in
Yeah.
another way. So yeah, that's another thing too, probably.
Mm-hmm. So since your siblings vape, is your family okay with it?
No.
No.
No. My dad, I have not told my father that I do or ever have. No, he doesn't know. My mom does, and she's not happy with it.
She's not happy with it?
Yeah.
So would you say that's another downside?
Yeah.
Potentially?
Yeah, that would be, like, I would not want my dad to know.
You wouldn't want him to know?
No, because I know he would not be happy about it.
Mm-hmm.
So yeah, that is a big thing, actually.
Yeah.
I didn't think about that. Yeah.
Yeah.
Trying to hide it. Yeah. That's a big one.
No, it's okay. That makes sense. So
Earlier, I was asked about resources. Oh, here we go. Okay, so I mentioned earlier that unfortunately in 60 minutes, I could not teach you MI as a patient-centered technique. But hopefully I was able to give you some things to think about that might encourage you to want to explore the idea of MI a little bit further. There is this great website. It's www.motivationalinterviewing.org. And it is the site that's maintained by the Miller and Roldick and Teresa Boyer's group. They're out of New Mexico. And they also published a book, Motivational Interviewing in Healthcare, again by Miller and Roldick. And those are some resources that you can go to look for more material. I actually got my training, MI, before I went for my doctorate degree. I went to motivationalinterviewing.org, and I found, believe it or not, I live in Kansas City. I found an introductory MI course by an addictions counselor in Emporia, Kansas. It's about 2.5 hours, 2 hours west of me. If you go into, Kansas and out into where the Flintlocks start, kind of out in the prairie a little bit. That's where I took my first course. It was a full weekend, all day Friday, all day Saturday. I even went back to the same individual for an advanced course, and I've been studying it ever since. So I hope these resources will be helpful to you. And I appreciate you joining me today, tonight, whatever part of the world you're in, especially because there are so many pressing things going on in our world. So if you have a question for me, I will now open it up to questions. Thank you so much. Yay to all of you. Great audience. So I think my text chat is going, oh, here we go. Aw, that's so sweet. So many of you saying thank you. You're welcome. And let's thank Phillips for bringing this topic to you and doing it at a great rate, right? You can't beat free. So quality programming provided to you because they want to support you as a professional. That's what I like so much about working with them. I don't see any specific questions. Yes, so a couple, Kathy, hi Kathy, commented about that first-year student. With regards to books, I would recommend definitely the MI in Healthcare is a great book to start with. And it does cover MI strategies. So that would be a good jumping off point. Oh, okay. So I'm seeing some people asking about patient recommendations. The fact that you still have a legal obligation to share their status with them, their disease status with them. And so the idea is to ask permission, share. Most of the time, people are going to say, yes, you can share that with me. That's why they came to the office. So you share that disease status with them. And then you try a few of these techniques instead of the traditional techniques to ask what they think about that information that you just shared. How do they feel about it? Have they ever heard of that before? Just opening up the conversation. All right, I think, so why don't they offer MI training in offices? I think it's because right now there are not a lot of people in dentistry, dental hygiene that could provide that type of training. But I certainly would be open to doing that type of thing. The introduction to MI, though, takes about 16 hours. So it's like an all-day Thursday, all-day Friday, or, it's really a big commitment. It's not the type of CE that we're used to. So hopefully we'll see more courses offered at CE meetings when you're spending the whole weekend there anyway. So maybe we could fit MI training into some of those types of courses that we offer. Okay, I think that's the last question. So once again, thank you to Philips for asking me to present tonight. And thank you to all of you who tuned in and participated from the comfort of your home or your office or wherever you get your webinar from.